Everything you wanted to know about gastroenterology is right here in these papers. Stay tuned. Good evening. Tonight's guest is Dr. Greg Machiko, and I just want to tell you I lied. Everything about gastroenterology is not in these papers. It's right here.
There you go.
Welcome to the show.
Well, thank you for having me.
How are you?
Doing great today.
Excellent. Tell us a little bit about gastroenterology, since I told the folks at home that it was in these papers.
Okay. Well, gastroenterology is the study of the GI tract, including the esophagus, stomach, small intestine, large intestine, liver,
Okay.
pancreas. What else can I ask?
So it's where the food passes through. You're the guy.
That's it.
Okay. Tell us a little bit about normal anatomy before we get into abnormal anatomy.
Well, the GI tract is actually fairly long, starting at your lips. The esophagus is, perhaps a foot long.
Okay.
The stomach's and maybe another foot long.
Okay.
Small intestine, we get a little big there, about 20
Okay.
feet long.
Okay.
Colon, averaging 6. Some people have 12. Some people have 4.
Feet, that is, not
4
intestines.
feet.
Okay,
Not a
good.
4 intestines, 4
Okay.
feet, right.
Don't try to confuse the people out
Okay.
there tonight.
All right.
Okay. Specifically, let's talk. One of the things that, when I was growing up as a doctor was peptic ulcer disease, and it was caused by stress, cigarette smoking, and alcohol and aspirins. Now we find this not to be the case. True or false?
Yes and no.
Ah,
How about that?
go ahead.
Everything you mentioned is a risk factor.
Okay.
Alcohol, tobacco, stress, significant stress as a surgery, a brain injury, a burn. Those big stresses. Daily life stresses, we're not real sure. It'll make you feel poorly, but it may not cause an ulcer. But indeed, what I think you're alluding to is the H. pylori, or the bacteria that we think can lead to peptic ulcer disease. Now, 10, 15 years ago, we thought this was perhaps the 90% reason for ulcers. In Australia, maybe, because that's where it was discovered. But
I see.
locally here in Western Pennsylvania, these days, I would say 15 to maybe 25% of ulcers are caused by the bacteria.
Okay.
Around here, it's going to be aspirin use. The population's a little older, and people listen to TV, and they take that one baby aspirin a day, and that's
Right.
going to be enough to give you an ulcer.
Well, now see, we've got plenty of guests this year which will say that baby aspirins are good for you.
Oh, they are.
Okay.
They are.
They're good for you, too.
Well, they're good for me, too.
I
They may keep you from having a heart attack or a stroke, but they
Okay.
can cause an ulcer.
Okay.
I have to say, it's not 80%. It's probably in the single digits.
Okay.
But if you have 100,000 people, even the single-digit percentage is going to be a lot of people.
Gotcha. Tonight's guest is Dr. Greg Machiko, in case you just tuned in and clicked off of the hockey game. Greg is a gastroenterologist board certified working at Canonsburg Hospital, talking about peptic ulcer disease and some of the causes. Okay, so we have what you mentioned, which is the bacteria, and which I mentioned was the smoking, because I love to talk about smokers and alcohol use. Are there any other risk factors, coffee, caffeine, soda, any of that stuff, cause any problems with that?
Probably 1 or 2 cups of coffee a day could be okay for you. Some people are very sensitive. Some people, 1 cup of coffee, and they're going to get dyspepsia or upset stomach, indigestion, things like that. It's an individual basis, but certainly if you're drinking 6 Mountain Dews a day, you're at risk.
Okay. Now the folks at home, probably long before they come to see you or I, have stopped in at the local grocery store. There seems to be Walgreens on every corner these days, or going up or there. And I'm certain they get all the over-the-counter medications and take them. Are there any of those medications they should be very careful that they take on a regular basis?
Well, in someone who has indigestion, okay, that's a symptom, and they're not necessarily specific or any particular disease. Indigestion or heartburn, any kind of a funny feeling in the stomach.
Okay.
It could be many things. It could be an ulcer. It could be acid reflux disease or
Okay.
heartburn. It could be a tumor. It could be a cancer. If you're 20 years old, it's probably not a tumor. It's
right.
probably too much cigarettes and caffeine. If you're 50 years old, you have to start thinking about a little more serious things.
Okay. If somebody has symptoms, they don't get better with these over-the-counter medicines, are there any other things they should do before they pick up the phone and call you?
If you have, say, intermittent heartburn, intermittent indigestion, that maybe once or twice a week, it goes away with 1 or 2 Tums or Mylanta, you're probably a pretty average person and have very low risk of having a problem. If you've gone and taken the Prilosec OTC or some of the pretty strong medicines for 2 weeks and got better, but then got worse again, okay, that could be a problem.
Okay.
And in fact, even on the label, the box, it says if you're not better in 2 weeks, you better call your doc. And the reason for that is you could have what's called a complicated ulcer, or simply a big ulcer that's may not causing much symptoms, but certainly can cause bleeding. Or, unfortunately, when you treat with the very strong acid antacid medicines, Prilosec, Nexium, things like that, you could be hiding the symptoms of a tumor.
Okay. What are some of the other, in the old days they talked about not eating before, after 9 o'clock, I'm sorry. What are some of the baselines that you tell people that have reflux?
Well, first of all, they probably should at least try to be on a low caffeine diet. Some people need their coffee in the morning, and 1 or 2 cups is okay.
Okay.
Certainly 4 or 5 cups, 3 or 4 Mountain Dews, not a good idea.
Right.
We tell them to eat actually low-fat diets. Fat actually relaxes the muscle at the end of the esophagus. When that muscle relaxes, it allows the acid and whatever else in your stomach to splash up and burn the esophagus.
Okay.
The one other thing is actually overeating is a problem too. Some people may not eat breakfast or lunch, but they come home and eat a really
right.
big dinner, and then maybe have a snack, a little bedtime snack. Those are probably things you shouldn't do. It's tough on a Steeler game night or a Penguin night, but
I was just thinking about the average Steeler fan out there.
But overeating can put you at risk simply because it fills your stomach, and you go to bed, you lie back down, and you can overcome that muscle that separates your esophagus from your stomach.
So the stomach makes a fair amount of acid.
Yes, it does. Yes, it does.
And the medicines that we give them, do they affect that in any way?
The antacids, the Mylanta, Maalox, and Tums, it's just like a high school chemistry experiment. You have an acid and a base, you put them together, you get salt and water. Okay, that works for, half hour, 20 minutes, something like that. And that's okay if you overeat, you have a little bit of pizza, and you need to put the fire out. The next step would be the H2 blockers, or things like Tagamet or Zantac or Pepcid AC. Those are good medicines. Take a little longer to work. They actually have to be absorbed and then work. The last over-the-counter drugs, which used to be prescription until a few years ago, were what's called the proton pump inhibitors. Those are things like Prevacid, Nexium, Prilosec. They take quite a bit of time to work. In fact, a medicine like Prilosec OTC could really take 6 to 12 hours to start to work, and really you need about 3 days for that medicine to really get a blood level to take care of your acid reflux. So if you're going to go on Friday night, you may have to start taking your Prilosec on Tuesday night.
Got it.
Okay.
How do we diagnose an ulcer or gastritis?
The best way, the absolute gold standard, state-of-the-art way, is to do endoscopy. Actually look inside with a video camera and see what's going on. Okay. Once we see if it's an ulcer there, we can look at it grossly, or what we see is if it's an ulcer that looks benign or non-cancerous, it has certain characteristics, things that look like cancers, and have other scary characteristics. Okay. We do a biopsy, and also, again, check for that infection, the H. pylori, or Helicobacter.
Okay. How do you do the endoscopy?
It's usually, as an outpatient, it can be an outpatient test. Certainly we do some on inpatients in the hospital, but it's an outpatient test. The night before, nothing to eat or drink after midnight.
Okay.
I don't want to see Cheerios and coffee in the morning. Okay. So I like an empty stomach. It's easier. They come to the hospital. The nurses will get them prepped. Usually, if they're going to have IV sedation, most people take IV sedation.
Oh, yeah.
That's just a small little plastic needle in the vein. We give them some sedation. It's not like an operation like you do where they stop breathing and an anesthesiologist has to be there. Right. This is basically, they get relaxed. We take care of anxiety, and also we take care of pain or discomfort. It's not a very painful test at all, but if we take the anxiety away, people do very well.
Perfect. How long does the procedure take?
It could be as short as 2 or 3 minutes, but if we see something, if we have to do biopsies, if we have to fix something, it could be 5 to 10 minutes.
Okay.
Yeah.
So very, very routine, very straightforward check. So the summary is if somebody's taking these medicines for a prolonged period of time, they need to pick up the telephone, give a call to their doc, call to you. Again, it's Dr. Greg Machiko, board-certified gastroenterologist tonight, talking about GI problems. How's that?
Sounds good.
Okay. We've taken care of the ulcer deal. Let's talk a little bit about Crohn's disease. Although it is rare, let's talk a little bit about it and see where this discussion takes us.
Okay. Crohn's disease is an inflammatory disease of the intestines. Crohn's disease can be anywhere from the lips to the anus. It's usually in the small intestine. We call it the distal or terminal ileum. Basically, it's the end of that 20 feet of intestine, right where the intestine connects to the small intestine, connects to the large intestine, right down by the appendix and the right lower side of the abdomen. I'd say about 40 to 45% of the time, that's where it is. What does it look like? It could be anything from what we call aphthous ulcers, or the little tiny whitish ulcers. Some people get them on their tongue if you eat too much salty things. That's not Crohn's. That's just what they look like. And or they could be serious, in which the ulcers actually literally burn through the intestine, sometimes connecting structures that aren't supposed to be connected.
Got it. What are who gets it, and what are some of the symptoms that you'll get with Crohn's disease?
Crohn's disease has what we call bimodal distribution. It just means that there are 2 main age groups that get affected. Usually it's children, and I shouldn't say children, maybe
young adults.
Young adults, I would say.
As we get older,
they become children. Yeah, okay.
I'm with you.
So, some between 12 to 30, say. Okay. And then there's another peak, say, between 55 to 70, somewhere around there. Certainly more people get Crohn's in their young adulthood.
Got it. What are some of the symptoms?
The symptoms could be significant. In fact, you may have bleeding, diarrhea, severe abdominal pain, nausea, unable to eat, weight loss. They could also be fairly benign, where you just don't feel well. Maybe you're not, little rumbles when you eat, things like that.
How do you make the diagnosis? More people have gallbladder disease than they do have Crohn's disease. How do you differentiate between the two, or there's obviously a lot of ways?
Well, you take a full history and do a physical exam.
Talk to the patient, in other words.
Yeah, you have to sometimes. Yeah, you got to. And basically, they're going to tell you what's going on. They're going to tell you, even though they don't know.
We went to the same medical school,
as we interrogate them, yes.
The patient will tell you what they have.
That's right.
Just have to listen.
That's right.
Okay.
So after we do the history and physical exam, there are some clues, some other things. If they're having, depends on where they have the pain, if they're having diarrhea. Okay. Also with Crohn's, there could be other we call extraintestinal manifestations. Big word means it's something else. It's Crohn's disease, but it's affecting some other organ. We can get rashes, things like that.
Are there any ways to prevent it? Can you catch it from somebody?
You can probably catch it from your parents. We think it's probably a genetic disease.
Cute.
And we think, at least this time, it's really an autoimmune disease. It's a self-destructive disease, sort of the way that rheumatoid arthritis that destroying arthritis would do.
The body attacks itself.
Right, and we think, at least at this point, that you're born with a tendency. You're born sort of with a lock.
Got it.
And if you, in your lifetime, in your experience, turn the lock with the right key, basically a virus infection or food or environment or whatever, if you turn that key, just like turn on the car,
got it,
you can activate the Crohn's.
So we still have some theories out there. There's nothing is exactly known to say this is what causes it, no question.
We're pretty close.
We're getting close.
We're getting close. I think it's going to be the autoimmune problem.
Well, we certainly know how to treat it. Why don't you tell us how to treat it, or how you go about treating it?
Okay. Well, first we'll back up a little bit. We have to diagnose it. Okay. Usually it.
That's a good idea.
That's a good idea.
Go ahead.
We'll, depending on their symptoms, most likely they'll have a colonoscopy, which is an evaluation of the colon. Scopes inserted through the anus, and we'll go inside.
Again, patient under sedation.
Under sedation. Or they could...
Heavy sedation.
They could take it like a man.
Right. I understand.
Okay.
Right.
Most people do take sedation.
I bet. Okay, go ahead.
And actually, when we evaluate the colon, we can actually get into the small intestine, and we can look there. Okay. Sometimes people will have, in rare cases, Crohn's of the stomach, Crohn's of the esophagus. So if they're having upper symptoms, we'll evaluate them in that way. So anyway, we establish a diagnosis. And
endoscopy, colonoscopy, sometime upper GI with a small bowel
series. Okay. So once we establish where the Crohn's is, and what the extent is, what the severity is, then there's, right now, the old way, which is 5 years ago, that's the old way, was the therapeutic pyramid, where you'd start with some medicines. They're called 5-ASA products. They're sort of related to aspirin, but they're not absorbed in the body. They simply sort of coat the GI tract with an aspirin-type substance. Then the next was steroids, things like prednisone, not the growth hormone steroids, but prednisone with asthmatics use and things like that. And then we go to the, it's called immune modulators. And those are actually drugs that sort of adjust the immune system a little bit. We're going to sort of downregulate the immune system. And now the newest thing, the tip of the pyramid there is called biologics. Basically, molecules designed by computer that actually absorb some of the chemicals that Crohn's produces to cause the pain. It's pretty neat stuff.
Space age stuff. We got tonight's guest is Dr. Greg Machiko. We're talking about GI maladies, specifically about Crohn's. Tonight we talked a little bit about peptic ulcer disease earlier. When we talk about Crohn's disease, it's not that common, is it?
Compared to gallbladder disease, compared to heart disease, compared to asthma, no. But it tends to strike the people who are sort of in the prime of their life. They're the younger people, the people who are going to school, getting their first job, things like that. So it can be devastating on your life in general. It's not like a disease like hypertension or diabetes will kind of hit you later in life.
So, but it's treatable for the most part?
I would say that most people can be treated. Probably less than 5% need emergent surgery, do poorly, and there are some people who die, but it would be unusual to die acutely, basically to be diagnosed today and be dead next week.
I'm with you 100%. Can Crohn's disease turn into cancer?
It's a yes and a no. How about that for a hedge?
A lot of yes and no questions.
We think that chronic inflammation of the intestine, especially the colon, large intestine, can lead to precancerous lesions or sometimes polyps. But I would say that if someone who's had Crohn's disease for more than 12 years, they increase their risk of having a colon cancer about 1% a year. Okay, so if you're 20 years old and get Crohn's, and then you're 32, you should probably start to get screened, start to be evaluated regularly for colon cancer, because indeed, 30 years later, you have a 1/3 chance of getting colon cancer.
I'm with you. Besides, there's this new thing I've heard about capsule endoscopy. Does that have any Does that help at all? Not help? Have you find that
Capsule
to be of any
endoscopy
benefit?
is an emerging technology. It's
Tell us what it is. 'Cause,
Basically,
I mean,
what it is.
folks
It is a capsule, pretty large capsule actually, like a big vitamin. Has a TV camera on it, and has a little transmitter. And you swallow it, and it sort of tumbles through your GI tract. And you actually wear, just like any wireless device, you wear a little tape recorder or a little device that actually records the video.
I got a question.
Uh-huh.
Did you grow up with the Jetsons? Because I mean, that's just tunes playing in my head right now. Is that bad? Remember that Astro guy?
Well, it's only bad because I'm thinking about that too.
He swallowed this television camera.
That's it.
That beams out. That's beautiful.
That's it.
Okay.
You could, I guess, get your own webcam and do that. I guess you could do that. So, but
Oh, Lord.
it's useful in bleeding that we can't figure out where.
Can you pick up any other TV? Could you watch the Penguins if you didn't like it? Click the.
Maybe if you
click
had
it off
interference, I guess you get a little bit of small
I'm
bowel.
messing with you now, man. I'm sorry. Go
That's
ahead.
all right.
Me, George Jetson is just going through it. I got a lot of problems. I got a lot of issues.
But I know that. So that's
Okay,
I'm here despite that.
Okay,
Anyway.
so we're back to capsule endoscopy,
Okay. So
swallowing
the-
television stations.
The camera basically tumbles through your small intestine, and it takes pictures and it records them on a recorder. That
It's like
recorder.
Alfred Hitchcock's Vertigo. I mean, this thing's spinning around.
That's it. And
How
well,
do they stop
that is the problem
That's
because
what I was thinking. Can I
it,
adjust this TV set? This thing.
the technical problem with it is,
man.
when we do endoscopy, we actually have a fixed camera, and we
understand.
look there. The capsule actually can tumble. It can travel like a snake, but that's unusual, kind of tumble. So the picture's not really great. You need to
understand.
get the vertical hold
I bet
fixed
you
there.
do.
So, but anyway, that would
Don't
be.
eat before you watch this movie. Go ahead. I'm sorry. Fantastic voyage through
Now
the
that's
colon.
that's
Now that was a good one.
there you go.
Okay.
So
Man.
after we get
Every
the
once in
pictures,
a while, I just shouldn't ask a question. Go ahead. You talk now for a while.
after we get that's
Go ahead.
after we
Okay.
get the
Is it
pictures,
helpful? Yes or no?
we
Let's just go
interrogate.
right. Let's get to the end
Well,
of the story.
the answer is if you got
Don't
Crohn's.
say yes or no one more time.
No, no,
That's
no.
all I can
The
say.
answer is it can be helpful.
Okay.
But there are some relative contraindications, which means there's sometimes you shouldn't do it. If you got if you have Crohn's that you could see on an X-ray,
Right.
there's a big chance, a good chance that pill can get stuck.
Right.
And I know
Then
you
you'll
don't-
need me.
And you don't mind that because you have to
No,
go in and take it
not
out.
at
But
all.
a lot of people don't like their intestines corked.
I understand.
Okay.
I'm with
so
you 100%.
you know
Use this judiciously. You want to check with a gastroenterologist before somebody says, hey, let's go out and get a capsule endoscopy.
All right.
Perfect. You want to talk about irritable bowel?
Sure.
Okay. You're an expert in gastroenterology. What percentage of your practice would you say is irritable bowel related?
Well, probably 100%.
It can't be 100%.
But
You do other things.
No. What I'm saying is, I think it's very common. If you took 100 people off the street and you asked them questions that would suggest irritable bowel, probably half of them would have some form of irritable bowel. Now, what is that? Is that it could be bloating, a little nausea, a little queasiness, a little too much constipation, a little loose stools. So it's a very common disease. Now, when it's debilitating or if it's really interfering with their life, that's when they're seeing me. The primary care docs that we deal with know how to treat average, routine, run-of-the-mill irritable bowel. But I'm going to see people who really are on that fringe, and that answer is about 20%.
Got it.
Get back to the first answer.
So, all right, well, let's get back to some of the more common things that we see, that you see, that I see. How about gallbladder disease? I'm certain you see a lot of that.
Right.
Talk a little bit about biliary dyskinesia. That seems to be a topic of the day, chronic cholecystitis.
Okay. Biliary dyskinesia. Biliary simply means bile ducts and gallbladder. Dyskinesia, what's an easy term? Doesn't work right.
Right.
Would be an okay. So
correct.
It doesn't feel good. It doesn't work right.
Correct.
Well,
kinesia is the study of motion. So
right.
There you go.
Yeah. So biliary dyskinesia, usually in younger women, usually with a family history of similar disorders. Mom has her gallbladder out. Even dad may have his gallbladder out. We do an ultrasound, which is a sonogram test that sort of the simple, like the test
Just
that
like we're
pregnant women
checking
get.
for babies,
Exactly.
right?
Okay. And we'll look at the gallbladder, and it'll look fine. There won't be a stone in there. It won't be thick. It won't be thin.
So you're done. You're out of the woods.
Well,
Not quite.
no, I'm not out of the
Okay.
woods. That's where sort of I come in, and then
Okay.
we have to figure out what this pain's from.
Okay.
There's a test called a CCK HIDA. Basically, it's a stress test for the gallbladder. We inject the patient with a little tiny bit of radioactivity. It circulates in the blood, goes to the liver, goes to the gallbladder. And actually on the x-ray, or a special x-ray, we can actually see the gallbladder. And then we give them a medicine called CCK or cholecystokinin. We used to give them chocolate chip cookies with extra chocolate chips because all the fat in there. When you eat fat, your body releases CCK or cholecystokinin, basically making your gallbladder contract. All the techs were eating the cookies, so we had to use the medicine. Oh, we inject it with the medicine, and you would expect a response. The gallbladder, the job of the gallbladder is simply to store bile, store this detergent that the liver makes. And when you eat, to basically squeeze, release the detergent into the intestine, let everything mix up, like Dawn dishwashing liquid with fat. All the fat goes from big globules to little tiny globules, and you can absorb your fat. So we check, we want to see how well that gallbladder squeezes.
Got it.
We inject the medicine, and there's a certain parameter, certain percentage. We usually more than 35 and up to 100% really. If, say, we have a person who really looks like a bad gallbladder, talks like a bad gallbladder, but we can't prove it's a gallbladder, this is the test that's going to show if it really is a bad gallbladder. We do that, and if that number's lower, that's when you see that patient.
Well, we appreciate that very, very concise biliary tract discussion. There is certainly what we've spoken about. Clearly, there's an overlap between biliary dyskinesia, between ulcers, sometimes Crohn's, but much more likely biliary dyskinesia with a bad gallbladder. I'm sorry, an ulcer, and that's where you come in.
Right.
So you're able to differentiate that for the viewing public.
We try.
Okay. It's Dr. Greg Machiko. You can get a hold of him at the number that should flash across the bottom of the screen. As always, if you have any questions, Greg would be more than happy to answer them by phone, telegram, telegraph, email.
Smoke signals.
Smoke signals. He's located at the hospital. Those tests that he spoke of, HIDA scan, CCK, endoscopy, can all be done at Canonsburg Hospital with state-of-the-art equipment, including the capsule endoscopy if you want to have that television camera flipping back and forth through there.
There you go.
Greg, thanks for coming. If there's any questions the folks at home would like to give Greg a call, we certainly appreciate it. As always, get a hold of the docs at Canonsburg Hospital via the same number. Again, I'd like to congratulate Dr. Machiko for an excellent job this evening. I'd like to thank you for coming. I'd also like to congratulate all the high school sports teams who have done a phenomenal job this fall. Good luck to the winter sports, which are coming up shortly. And again, thanks to all the high school volunteers, adult volunteers at the cable network here that keep us on and keep us running. We certainly appreciate it. Now go out there, drive carefully, be safe, try to cut back on the cigarettes and fats so you don't see this guy, especially the fats. Have a good one.